This is one of my favorite topics. When we originally planned this, it was a longer time, so I'm going to flip past a lot of these slides, and we'll bring out more things in the discussion. So I'm going to start with the New England Journal from 1984. In the same issue, the journal teed up today's topic. And Marty told me my first slide from Norman Levinsky is his last slide. This is an article probably a lot of us know. It's a real classic. It looks like the bold shows up a little bit. Norman Levinsky made the point as strongly, as powerfully as anyone. Caring for an individual patient, the doctor must act solely as that patient's advocate against the apparent interests of society as a whole, if necessary. I never knew Dr. Levinsky. He was a very revered teacher and physician. I'm sure I would have admired and respected him, and I think this view is completely wrong. And I've been tilting swords with it since it was written. In the same issue, and we can really feel proud of this in Massachusetts because Norman Levinsky was chief of medicine at BU for 25 years. Lester Thurow was an economist and dean of the Sloan School. And in the same issue, he had a piece called Learning to Say No. And he made the case, this is in '84, I won't read the whole quote to you, but the key part is going to connect to the next slide. He said here that we physicians should begin to build a social ethic and behavioral practice to help us decide when medicine is bad medicine. He put it as an economist would, where the costs are not justified by the marginal benefits. So those two pieces were there in the same issue. That was really prescient on the part of the journal. I'd forgotten until I went back to Thoreau's piece that he predicted in '84 what was really the fiasco of 1990s managed care. So he said, if we physicians developed norms of cost-attentive practice, as the specialty societies are trying to do now in the Choosing Wisely program that Jean talked about, he said, it may be possible to build up a system of doctor-imposed cost controls that will be much more flexible than any system imposed by third-party payers. Well, we didn't do it. And what happened in the 90s was, unfortunately, actually two things happened. As Jean Lindsay spoke about a bit, in 1969 in Massachusetts, the dean of Harvard Medical School, Bob Ebert, fostered the founding of a not-for-profit, physician-led, capitated practice, the Harvard Community Health Plan. Jean and I joined that practice in '75 at the same time. But what happened over time and into the 90s was that these physician-led entities receded into the background and the large national for-profit insurers took over what managed care is. Here's my analysis of why it crashed and burned managed care 1.0 in the 90s. And this slide, I think, is useful because if ACOs are going to succeed, like Atrius, as Jean was discussing, they would have to do the opposite of what's on this slide. This is kind of the nightmare vision. So cost containment policies, how were they established? They were set at a distance by insurers. And these policies, I don't know how many of us experienced this, were often treated as proprietary, the opposite of openness and transparency, as proprietary secrets. That was a preposterous and monstrous policy. And it was a preposterous policy not because of the content, but because of the secrecy. It's the opposite of what we need to do. And they were enforced by 800 numbers. Those of us who practice then know the jokes. 1-800, just say no. 1-800, nurse, please, may I? A big part of the problem was that physicians and patients doubted that savings were being put to a good purpose. It's one thing to be cost attentive, but if you're cost attentive without having any sense of what your prudent practice is conducing to, it makes no sense. One can't put one's heart into it. At the time, the public leaders didn't endorse the insurance rule, and it was a model that was destined to fail. If you split, I don't know how many psychiatrists are here, but if you split cost responsibility to an insurer and clinical responsibility to a clinician, and they're connected by an 800 number, all chaos is going to happen, and it did. So these two slides are our own policy from the AMA. Now, in '81, the AMA first took a stand on being cost conscious and did it in a somewhat tentative way. So it said, we should be conscious of costs and not prescribe unnecessary medical services. Well, that's sort of obvious. And the second sentence shows the hesitance. This cost attentiveness does not preclude us individually or through others being active. I got it a little backwards, sorry. The primary commitment to our patient doesn't preclude our attentiveness to cost. We can participate in policy making. So from '81 on, in our ethics code, there was I hear the tone is slightly grudging, acknowledgement of an ethical responsibility, not just a business imperative, but an ethical responsibility. I spent time in the UK in the 90s, and there, in the British Medical Association ethics code, they were quite direct. They said, if two treatments have comparable outcomes and one is less costly, it is unethical to prescribe the more costly one. Unethical. And they just went on to say, because it's a system with a budget, if we spend more money than we need to over here, it will lead to ward closures or letting go of nurses over there. So that quality of knowing what was happening with the savings made for that strong difference on cost attentiveness. Just this year, the AMA strengthened the endorsement of cost-conscious practice. And it's quite striking. Have any of you read the document on stewardship? It's actually quite good. This is the essence of the view, that clearly our primary ethical obligation is to promote the well-being of individual patients. But then they go on to say, we have a long recognized obligation to promote public health and access to care. Okay, we can accept that. But here's the strong point and the change of tone from 1981. This obligation, I put it in the underlining, requires us to be prudent stewards of the shared societal resources with which we are entrusted. And then managing healthcare resources responsibly for the benefit of all patients is compatible with our primary responsibilities. Personally, I take that as a no-brainer. I don't think that has to be argued for. The way I first started to think of it is, and this is what I thought was wrong with Norman Levinsky's really noble statement, that we only think about the individual patient against all other interests as needed. It occurred to me, that would be like a parent at a table with many children sitting around and one pie. And I say, Johnny, how much pie would you like? Let's not think of anyone else or anything else, my only consideration is how much pie you want, that would not be optimal parenting. I'm going to skip these slides here. This is a diagram that we found useful at Harvard Community Health Plan, and I found useful in my teaching. It's an effort to convey that within a health system, we want all parties to hold two basic values: the value of fidelity to the interests of individual patients, and the value of stewardship of the public good, which doesn't only mean shared resources, but that's what we focus on. But if you look from the top to the bottom, the point is we want ourselves as clinicians, for us, the fidelity value should predominate. That's what we should primarily be thinking about. But we want this was within the practice. We developed this for the practice. We want our physicians, along with that value, to be aware of the multiplicity of patients, the population in need. And so if I give all the pie to Johnny, Janie isn't going to get any over there. And in the leadership, like Jean Lindsay, we want stewardship to predominate, but we don't want them flying at 35,000 feet without being aware of the implication for individual patients of what's happening on the ground. I'm going to go over this quickly, but cost-conscious practice, our accepting it as physicians, our patients accepting it, and the public accepting it, is an adult version of what we all go through as kids growing up in learning to share. Learning to share has cognitive elements. So we talk with children about fairness. You've played with the toy for a long time. Now Johnny gets to play with it. That's fair. But the big part of learning to share is emotional. So when I drop down on the floor and have a tantrum, that's really when the learning is happening, and I get over that and I share the toy and life hasn't ended. The same is really true about cost-conscious practice, and I won't say more about that. It's a whole big topic. Now, the metaphor of numerator and denominator is useful for us as physicians and over time for patients and the public to understand. In order to understand and accept as an ethically, not just acceptable, but admirable approach to healthcare, and I'm putting this in terms of Massachusetts because of where we are right now, we have to understand the numerator, the patient's needs and desires, and the denominator, the Massachusetts population. That's where, as powerful as Dr. Levinsky's piece was, I think it missed something important. I think it left out the denominator, which we need to have a feeling for the same way we do with our patients. And similarly, we need to have an understanding of the fact that our beloved sector is healthcare. So when we constrain any aspect of the practice, it's what we know best and are most attached to and place high value on. It's not the only human good. And I think of this very personally. One of my sons is principal of a K-8 in Dorchester. Teachers, the school system, they get the stuffing kicked out of themselves. The educational system is as important as our system. And every dollar we spend that doesn't have to be spent is coming from potentially valuable alternative sources. That's the denominator. Now, the most recent episode of law, Chapter 224, which is the cost containment law, is important. This is the signing, Governor Patrick, DeLeo, and Judy Ann Bigby in the background. It's important because the imperative to attend to costs is ultimately coming from ourselves as citizens through the legislature. This is not a national for-profit insurer legislating something from Hartford or from Los Angeles, depending on where the corporate headquarters are. This is us. We set, I don't know how familiar everyone here is with Chapter 224. It has explicit cost targets that till 2017, the rate of growth will only be a half a percentage point over the state gross state product, and then a period where it's the same, and so on. I may have gotten the numbers slightly wrong, but that's the principle. Okay, now I want to shift to some practical things. I've summarized a dialogue I had in a range of forms many times in the Harvard Community Health Plan practice. The major resource in terms of finance that a psychiatrist uses is the hospital. And I actually had a year of my residency in a day hospital. I had a very good experience from the start in partial hospital care, outpatient emergency care, and so on. So I would see a patient in crisis, often with a family. And in the past, that person may have been hospitalized at McLean or somewhere else, had a good experience, same symptoms flaring up. That's where I need to go. That's what I need. So I say, in effect, this is just condensed, I believe we can handle the situation well without using the hospital. And then I'd propose a plan that actually I knew a fair bit about from my own experience. And I'd hear from the patient and the family some version of, Dr. Sabin, you're just thinking about cost. And often there'd be a great deal of heat associated with that. And my basic response was what I put here, that I agreed with them except for the word just. And here's the key part. I and my family, we had our care through Harvard Community Health Plan. So in my response, I could say we. It wasn't me to you. We members, that invokes a community image. We members of Harvard Community Health Plan should want our doctors and nurses to pay attention to costs. That's how we can offer services like such and such. And I would try to cite something that was meaningful to the person. At the time, we had an unusually good partial hospital program, which I might have been referring the person to. It was a rare bird those days. And the way we could afford that was by cost-attentive practice. So it was a little bit like the same ethos of the ethic of the British Medical Association. Okay, a series of points. I'll try to bring in some practical things and then wind up. Dealing with limits in healthcare. When you push on the topic and think about it in depth, it's a noxious topic. It rubs our nose in the fact of finitude, death, disability, the need to conserve resources for other purposes. And our societal impulse has been to avoid it. And the preposterousness of the death panel flare-up in the reform discussion speaks to just how far off base our whole societal approach has been. In order to conduct, believe in, justifiably believe in, not just brainwashedly believe in order to be able to practice in a cost-conscious way with a sense of ethical integrity, we need a number of things, and one is a sense of the denominator as well as the numerator. As I said, in Managed Care 1.0, whatever savings they were vanished, and one of the reasons people went ballistic over corporate bonuses, CEO bonuses, is that why should I why should I and my patient strain ourselves on behalf of this ridiculous, worthless societal purpose? Now, as I see it, as I said, I think the ethical imperative to practice in a cost-attentive way, I don't think it needs to be argued for. It seems to me just a basic truth. And I think the impediment to it is emotional. If you've been part of discussions on this topic, you've seen people flare up. It can evoke in us as physicians a sense of cataclysmic loss of the meaning and the value of what we do. So we're not going to move into better versions. We're not going to do it quickly. We're not going to do it without experiencing and addressing emotions, and it's going to take time. The Choosing Wisely program that Jean Lindsay referred to is an important precedent, and it's an important model. Cost-conscious practice will be more trusted by ourselves and by our patients if it's developed by deliberation within specialty groups, group practices, and in settings like this. When we're with our patients, we need to be able to use collective pronouns in a meaningful way. It's not that I think you don't need the hospital. We think such and such is a good approach. That requires that it be true. If it's just baloney, it's going to come across that way to patients. We ought to involve patients and the public in our deliberations about this, so that as we reflect on what constitutes, using the term that Jean used, standard practice with regard to cost-attentive practice, we've incorporated patient perspectives upstream, and we've in a sense done trial runs with people. If we're talking about diabetes, there should be people with diabetes who are part of the planning group. There should be parents of children with type 1. Point 11 here has tremendous power, and I experienced it a lot. Patients, the physicians, and the public are only going to trust cost-conscious practice, obviously, first consideration, if they believe quality of care is being preserved. But the second is that the savings are being used for a good purpose. I had patients ask me, how much will you get if I don't go into the hospital? And I thought that was a perfectly fair question. And we had a very meager bonus system based on the entire practice. So I could say, I'd sort of think, and I'd say, I'd probably get maybe 1/5 of a penny. But it was a valid and important question. I'm going to jump, because of time, to the last point. With regard to what Massachusetts has undertaken, and it's a big topic in itself, what Chapter 224 is trying to accomplish, we're the crucial players in it. We can make it work, and we have the power to be spoilers. We did with 1990's Managed Care 1.0. And while I've respected and admired the model of not-for-profit capitated group practice that I was part of at the Harvard Community Health Plan, and where my family got its care, I think we were justified in opposing the managed care version that I showed on the slides with proprietary practices and so on. That's not the case now. This is a state program. It's on behalf of our citizens. It's targeted to be done in an open and collaborative way. So I think our responsibility is to make it work. So my last words are, the choice is ours.